Hello, everyone. My name is Chastity Malone. I'm excited to present my final program proposal, which aims to address a critical public health crisis in Houston: the profound disparity in access to mental health services for children who have experienced sexual abuse. This presentation will outline the specifics of the proposed intervention, including the nature of the problem, the target population, the program's rationale, the logic model, detailed goals and objectives, program design, evaluation strategies, budget, and funding sources. The overall objective is to foster recovery and prevent long-term harm by bridging the existing gaps in trauma-informed care. This presentation provides an overview of a trauma-informed mental health intervention designed to serve child sexual abuse survivors in Houston. The program emphasizes culturally responsive, evidence-based care and multi-sector collaboration. The goal is to demonstrate how structured, trauma-focused services can improve recovery outcomes while addressing inequities in access for marginalized children. By the end, you will see how early coordinated and culturally competent interventions can prevent long-term psychosocial consequences and support the well-being of children and families across high-need Houston communities. Child sexual abuse is a pervasive and devastating issue in Houston, affecting thousands of children each year. Beyond immediate trauma, child sexual abuse leads to long-term psychological, behavioral, and academic challenges if left untreated, including post-traumatic stress symptoms, anxiety, depression, difficulties with emotional regulation, and impaired social functioning. Children in underserved neighborhoods often experience compounded barriers to care, such as lack of health insurance, limited access to trauma-trained clinicians, transportation challenges, and cultural or language mismatches between providers and families. These systemic obstacles create a cycle where many children never receive the early intervention necessary to prevent long-term consequences. Addressing child sexual abuse effectively requires a multifaceted approach that overcomes these barriers and ensures timely access to evidence-based, trauma-focused services while supporting caregivers and schools as critical partners in the child's recovery process. The program targets children aged 5 to 17 who have experienced sexual abuse in high-need Houston neighborhoods, including Gulfton, East Houston, and Northside. These areas were selected based on higher child sexual abuse prevalence and demonstrated gaps in trauma-informed mental health access. Primary caregivers are a key secondary population because their engagement and understanding of trauma recovery are essential to a child's healing. School staff, including teachers, counselors, and administrators, are another secondary population, as they play a critical role in creating supportive environments that promote safety, engagement, and academic success. The program prioritizes historically marginalized groups, including racial and ethnic minorities and immigrant families, ensuring that interventions are culturally responsive, language accessible, and sensitive to a child's unique social and cultural context. By targeting both children and the adults in their lives, the program creates a holistic approach to trauma recovery and long-term resilience. Early, evidence-based interventions for child sexual abuse survivors are critical because untreated trauma can have cascading effects throughout a child's life. Research demonstrates that trauma-focused therapy, such as trauma-focused cognitive behavioral therapy, or eye movement desensitization and reprocessing, significantly reduces trauma symptoms and improves emotional regulation. In addition, caregiver psychoeducation strengthens family support systems, while school-based coordination ensures that children receive consistent understanding and support in academic environments. Multi-sector collaboration, or connecting clinicians, schools, and community organizations, enhances program reach and sustainability, while embedding trauma-informed practices across the child's ecosystem. This holistic approach not only addresses immediate psychological needs, but also mitigates long-term consequences, including chronic mental health issues, academic disengagement, and increased risk of re-traumatization. The rationale underscores the necessity of a coordinated, culturally responsive intervention to break the cycle of trauma in underserved communities. The program's logic model outlines how resources and activities lead to meaningful outcomes. Inputs include licensed mental health clinicians trained in trauma-focused therapy, culturally responsive staff, and evidence-based materials for both therapy and assessment. Processes involve conducting trauma screenings, providing individual, family, and group therapy, and facilitating caregiver education workshops. Outputs are measurable units of service, such as the number of children served, therapy sessions completed, and caregiver participation rates. Intermediate outcomes focus on improvements in child's emotional regulation, coping skills, and caregiver support. Long-term impacts aim to reduce re-traumatization and re-victimization, improve school attendance and academic performance, and raise community awareness and responsiveness to child sexual abuse. The logic model visually and conceptually connects resources, actions, and expected results, ensuring accountability, fidelity, and continuous program evaluation. The goal of the program is to enhance trauma recovery outcomes and reduce long-term psychological risks for child sexual abuse survivors aged 5 to 17 in underserved Houston neighborhoods. Final outcome objectives include reducing clinically significant trauma symptoms in 75% of participating children by August 2028, improving classroom engagement and behavioral regulation in 60% of program-enrolled students, and increasing caregiver confidence in managing trauma-related symptoms in 80% of primary caregivers. To achieve these outcomes, the program sets intermediate objectives such as assessing and referring children to trauma-informed therapy, ensuring therapy engagement and completion, enrolling caregivers in psychoeducation workshops, and establishing school partnerships. Process objectives further define actionable steps like creating a culturally responsive referral intake system, assigning clinicians promptly, and providing transportation or telehealth options. Together, these layered objectives provide measurable targets that guide implementation and evaluation while ensuring accountability for program effectiveness and equitable access. The program design centers on three primary service components: trauma-focused therapy, school-based support, and caregiver psychoeducation. Trauma-focused therapy uses evidence-based approaches, including trauma-focused cognitive behavioral therapy and eye movement desensitization and reprocessing, to help children process and reduce trauma symptoms. School-based support involves partnering with Title I schools to train staff, assign liaisons, and monitor behavioral indicators, ensuring that children receive consistent support in educational settings. Caregiver psychoeducation focuses on building capacity to support recovery through workshops, printed and digital materials, and interpretation services. These services are underpinned by essential inputs and resources, including licensed, trauma-trained clinicians, culturally responsive bilingual staff, therapy and training materials, private and school-based facilities, and secure data systems for monitoring and evaluation. This structure ensures that children, caregivers, and schools receive coordinated, culturally competent support, improving both immediate and long-term outcomes. The client flowchart illustrates the program's structured approach from referral to case closure. Children are first referred by community organizations, schools, clinics, or self-referral. The intake and eligibility screening phase collects demographics, trauma history, and baseline child post-traumatic stress disorder symptom scale scores. After assessment, children are assigned a clinician within 1 week and begin trauma-focused therapy, attending a minimum of 10 sessions. Caregiver engagement occurs concurrently with workshops and access to language-appropriate resources. School liaisons coordinate support, deliver staff training, and track student behavior. Throughout the program, a data analyst monitors attendance, engagement, and outcome measures to identify gaps and optimize service delivery. Finally, case closure includes completing treatment goals, documenting final CPSS scores, and gathering caregiver feedback. This flow ensures comprehensive service delivery while allowing for continuous quality improvement and accountability at each step. Formative or process evaluation focuses on monitoring how the program is implemented to ensure it aligns with its design. This involves documenting participant demographics, the number of children and caregivers served, therapy sessions completed, and school engagements. Evaluation of effort includes questions such as age distribution of children enrolled, primary language of caregivers, and the number of therapy sessions delivered. Cost efficiency examines the resources required relative to outputs. For instance, average cost per therapy session or caregiver workshop. By assessing these elements continuously, program managers can identify bottlenecks, optimize resource allocation, and make real-time adjustments to maintain service quality and fidelity. Summative evaluation assesses the program's effectiveness in achieving its stated goals. This involves measuring changes in trauma symptoms, caregiver self-efficacy, and children's academic and behavioral performance from pre-test to post-test. Univariate analyses might include the percentage of children demonstrating clinically significant symptom reduction or caregivers reporting increased confidence in managing trauma-related behaviors. Bivariate analyses explore relationships such as the number of therapy sessions attended and degree of symptom improvement, or caregiver participation in children's school attendance outcomes. Cost-effectiveness evaluation is also important, calculating the financial investment per child achieving clinically significant improvement or per caregiver demonstrating increased self-efficacy. Summative evaluation allows stakeholders to see whether the program achieves meaningful change, informs decisions about program's continuation or scaling, and provides evidence of accountability and impact to funders and the community. Performance measurement is central to understanding how well the program functions and the outcomes it produces. The program collects and compiles 8 types of data: coverage, equity, process, effort, cost efficiency, results, cost effectiveness, and impact. Coverage data assesses whether the program reaches the intended population, while equity ensures services are distributed fairly among marginalized groups. Process data monitors fidelity to therapy protocols, and effort data tracks the quantity of services delivered. Cost efficiency and cost effectiveness evaluate financial investment relative to outputs and outcomes. Results data focus on intermediate and final outcomes such as trauma symptom reduction, school engagement, and caregiver confidence. Impact data measure broader community benefits, including decreased re-traumatization and improved resilience. By systematically tracking these metrics, program managers can identify successes, areas for improvement, and strategies to enhance program effectiveness over time. The program employs a single group pre-test, post-test design which is appropriate and ethical for child sexual abuse survivors. At intake, baseline measures include the Child PTSD Symptom Scale, or CPSS, for children and validated self-efficacy scales for caregivers. The intervention consists of trauma-focused therapy, caregiver workshops, and school-based support. At discharge, post-test measures are collected to assess changes in trauma symptoms, caregiver confidence, and school engagement. This design allows each participant to serve as their own comparison group, avoiding ethical concerns associated with withholding treatment. The evaluation captures meaningful clinical and functional improvements supporting evidence-based decision-making. By analyzing both quantitative data, such as symptom reduction and attendance, and qualitative feedback, such as caregiver satisfaction, the program can demonstrate its effectiveness, inform continuous improvement, and contribute to community knowledge on child sexual abuse recovery. The total estimated annual budget for the program is approximately $2,790,000. Personnel costs represent the largest portion at $1,850,000, covering the program director, clinical managers, licensed trauma-informed clinicians, intake coordinators, case managers, school liaisons, evaluation staff, and other key personnel. Operational costs totaling $365,000 include facilities, utilities, office supplies, technology, transportation support, and interpretation services. Program materials and resources at $105,000 cover therapy tools, assessment materials, and caregiver workshop supplies. Training and professional development, including TFCBT and EMDR certifications for staff and school staff training, are estimated at $115,000. Outreach costs, including events and partnership development, total $60,000. Finally, indirect administrative costs account for $295,000. This comprehensive budget ensures adequate staffing, high-quality service delivery, and effective evaluation, while maintaining sustainability and accountability to stakeholders. To sustain this program, multiple funding sources are identified. Federally, the Office for Victims of Crime, Victim Assistance Formula Grants, and the Substance Abuse and Mental Health Services Administration provide resources for trauma-focused services for children. State funding may be accessed through the Texas Department of Family and Protective Services and the Texas Health and Human Services Commission, which support child welfare and behavioral health initiatives. Locally, the City of Houston and Harris County offer community grants targeting mental health, youth, and family services. Private foundations, such as the Houston Endowment, the Cynthia and George Mitchell Foundation, and the Moody Foundation, provide additional philanthropic support. Strategic partners with hospitals, universities, and community-based nonprofits can offer in-kind contributions, co-funding, or collaborative programming. By leveraging multiple funding streams, the program ensures sustainability, maintains accessibility, and supports high-quality, trauma-informed services for child sexual abuse survivors across Houston. In conclusion, addressing child sexual abuse in Houston requires a trauma-informed, culturally responsive, and evidence-based approach. Early intervention is critical to improving children's emotional, behavioral, and academic outcomes while reducing the long-term consequences of untreated trauma. This program integrates trauma-focused therapy, caregiver support, and school-based coordination, creating a holistic system of care. Continuous evaluation, including formative and summative assessments, performance measurement, and impact evaluation, ensures accountability and facilitates ongoing program improvement. By leveraging diverse funding sources, engaging community partners, and prioritizing equity, the program provides sustainable, high-quality support to child sexual abuse survivors and their families. Ultimately, this initiative exemplifies how comprehensive, coordinated, and culturally responsive interventions can foster resilience, healing, and long-term well-being in vulnerable children and communities. Thank you for your time and attention. The references listed here provide the foundation for the key findings and recommendations I shared. I encourage you to explore them further if you would like more in-depth information. Once again, thank you.